I'll be talking about the MACALUSO inserter. As in the survey, it showed that it's one of the least used inserter systems for DSAEK. And even for me, coming across this instrument was a chance occurrence. I was at a meeting in Italy, and while going through the trade exhibit, I came across this stall from JANAC, which had displayed this MACALUSO inserter for DSAEK. I looked at it, looked at the video that was playing, and I thought it was quite innovative. It's basically a lenticule inserter which has a side-loading winglet, pretty much like the Busing glide. It has a sealing plunger, which allows it to be closed from the posterior aspect, pretty much like what you see with the endoglide. And this helps maintain a stable chamber, preventing it from collapsing. And you can do a very controlled delivery of the donor lenticule. The other things that you do require a microforceps to pull the graft in. They also have a nice 25 gauge microforceps that goes in through a small paracentesis. And you need an anterior chamber maintainer. And even a 25 gauge anterior chamber maintainer is sufficient because you don't need very high flow because it's quite well sealed with this device. So just to show you the video, it comes in two variants, pretty much like the endoglide, one for the standard DSAEK lenticule and the other one for the ultra thin. The standard one goes in through a 4.5 millimeter incision, whereas the ultra thin can go in from a 3.2 millimeter incision. So you can see that this is a DSAEK tissue that's been prepared. The endothelial surface is facing up. We put a little bit of heel on just to protect the endothelial surface. Using the microforceps, the tissue is pulled to the tip of the inserter. You put a little bit of ink mark just to be able to identify where the edge of the donor is. And you keep the AC maintainer running on, get the inserter into the eye, come with your microforceps, grasp the donor and pull it into the anterior chamber. You hold on to it till it unfolds. You can discontinue the AC maintainer at this point of time, let go of your donor, and then go and place an air bubble to do a complete air fill. And that's pretty much it. So you can see that it's a very nice controlled delivery, and it kind of opens up pretty well to be able to do the DSAEK surgery. For ultra thin DSAEK, when your corneal lenticule is less than 100 micron, it does not have the stromal rigidity. So when you try to transfer it onto the inserter, sometimes the tissue can try to flip the opposite way. So what I like to do is I put a little bit of viscoelastic and I do something like a trifold where I fold the edges inwards. So it's an endo-in technique. And then I take the trifolded technique, I take it onto the inserter. Thereby, I can ensure that I don't have my graft trying to fold the reverse way. And then you can pull it to the tip. Again, close it from behind, close the plunger. That makes it like a closed system. And you can see there we pull it into the anterior chamber. Because it's an ultra thin tissue, it doesn't snap open like a conventional DSAEK tissue. So you don't let go till you can get part of it to open up. Put an air bubble, and then sometimes it may require a little bit of manipulation. So here in ultra thin, we tend to use larger graft size than what we use for standard DSAEK because the grafts are thinner. So we often go up to 8.5, 8.75. You can see that the graft does not open up, snap open spontaneously. So it does require some tapping from the surface. And even the flow of the fluid from the AC maintainer can prevent the graft from snapping open. So if you remove the AC maintainer and then you find that by tapping and putting an air bubble in the anterior chamber, you can get this graft to open up. So that's the post-op appearance of the ultra-thin DSAEK graft. You can see fairly large graft, pretty thin, looks great. It's the anterior segment OCT, and again, another ultra-thin DSAEK graft using the MACALUSO inserter. There are no published data on the MACALUSO inserter looking at the cell loss, but in our experience, we have found that the cell loss is definitely lower. At 1 year, when we analyzed part of our data, we found the cell loss to range somewhere between 24 to 25%. And this is a great device, just that it's a little expensive, costs about 800 euros, but it's autoclavable, so you can reuse it multiple times, unlike a tan endoglide, which I think is a single use. So you need to pay every time you use, but this has the benefits of what an endoglide does, and I think it's a great device.